Welcome to the NEI podcast. In today's episode, we're coming to you from the 2024 NEI Synapse in Las Vegas, Nevada. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Hello, my name is Dr. Sarah Vinson, and I will be answering your questions about my panel presentation, Serious Mental Illness, a Collaborative Approach. I am a child and adolescent, adult, and forensic psychiatrist and have worked at the judicial mental health interface in various forms throughout my career, so providing direct patient care in a juvenile justice facility, providing services in a jail competency restoration program, and then throughout my career serving as a forensic mental health expert and consultant. So we'll go to the first question. Psychiatry as a field should really take the tact that homelessness is a social justice issue in a society that doesn't see the unhoused as something less than human. What are your thoughts on this? So certainly when we think about mental well-being, not just mental illness or the mitigation of psychiatric symptoms, the stability, the safety, the autonomy, the grounding that having a home provides are critical, right? You can't imagine what it means to be mentally well without a home and a place to call home. So absolutely, homelessness is a social justice and a mental health issue. And we know that we have all kinds of data, if we want to go the evidence-based practice route, that supports housing interventions for addressing mental health problems. And so it's going to take a sea change, I think, in the narratives around who is unhoused and why for society to get serious about addressing them. We've in a lot of ways, allowed the private sector to really dictate housing in this country. And part of why that's okay is that we think of unhoused people as people who are lazy or who didn't work hard enough, or maybe who are quote unquote crazy and scary, right? Until we start to talk about unhoused people in more nuanced, more accurate, less judgmental, less marginalizing terms, it's going to be easy for the markets to get away with continuing to treat them the way that they are. But I do think that there is a way that psychiatrists, given their privilege, their education, their standing in society as physicians, can be part of trying to change and shift that narrative to one that is more holistic, more humanistic, and that spurs people to take meaningful action in addressing this issue. Second question, regarding suicides and first incarcerations, it reminds me of the young African-American woman who killed herself in Texas. And in parentheses, it says Gladwell's book, Talking to Strangers, and she didn't have SMI. How can we better educate jail staff to recognize suicidal ideation warning signs? So when it comes to jail staff, one of the things that I think is under-recognized in the broader society is how stressed this population is, that these are incredibly hard jobs. And even before COVID, there were significant staffing issues in jails with there not being enough staff to go around, and that's only increased post-COVID. So the practical implication of that is, when someone isn't there for second shift, the people on first shift have to hold over and work second shift too. And so what you have is a setup, right, where you may have well-intentioned people, but the system does not put them in a position to be their best selves. It doesn't put them in a position to be their most empathetic selves. And they are often tasked with things that are simply impossible to do well for one person, given the staff to incarcerated individual ratio. So yes, there is a need for education of jail staff, but there's also a need for really radical system change within jails and in terms of workplace culture for people working in jails in order for that education to translate to real gains. Third question, please discuss court-ordered long-acting injectables with pregnant patients. So we do know that we have some data on the newer antipsychotics now as it pertains to people who are pregnant or even nursing. As with any mental health intervention, there's always the need to balance risk and benefit, right? So if you think about long-acting injectables, the fact that people are more likely to be adherent with treatment and be medicated consistently versus not, there's the risk of the long-acting injectable potentially, right? But there's also the risk of untreated mental illness and the risk of what it means to be somebody who has a severe mental illness, significant impairing symptoms, and also be trying to grow a human at the same time, right? And so if you have someone who has been stable on an antipsychotic medication, especially if it's one that doesn't have contraindications in pregnancy or in nursing, in most cases, the risk of stopping treatment is going to be much higher than the risk of continuing that treatment. Question number 4, how can we as providers be more helpful in reducing social determinants that affect mental health outcomes? Sometimes it feels we are forced to mainly focus on the medical side. Yes, that is absolutely true that the medical system, as it is currently configured and operates, focuses on illness. It focuses on diagnoses and on symptom reduction, right? We really don't get to think about whole health, and we really don't get to think about social determinants in the way that would be ideal if we were actually trying to promote a healthier society and promote mental health rather than just address or treat illness. I think it's going to take a lot of providers being very active, thinking outside the box, and really demanding that our field and that our workplaces are structured in a way that are better at addressing and identifying social determinants of health and how they're impacting people. So, for instance, even something as simple as having existing MOUs or agreements in place with food banks or housing shelters or transportation companies so that we're not just screening for these adverse social determinants of health, but that we actually have step 1, 2, and 3 that we take as a clinic or as a provider once these things are identified. And we've done the legwork on the front end that allows us to do that in a way that is effective and that helps people navigate these symptoms. I think it's great that we're starting to think about social determinants more. We're starting to screen for social determinants more. But by the time we screen, the exposure to the adverse social determinant has already happened. The risk has already been conveyed. So screening identifies the issue, but screening is not the work, right? The work is helping people navigate these systems. And in some cases where the systems are woefully inadequate, maybe most cases where the systems are woefully inadequate, being intentional about how we use our voice collectively and individually to help politicians and decision makers understand that there is mental health in all policies, right? There's mental health in housing policy and educational policy, food policy, just to name a few. Question number 5, how can we reduce the stigma and discrimination associated with serious mental illness, both within the healthcare system and in the broader community? I think that when it comes to stigma, the most powerful weapon we have is putting people who have mental illness front and center, right? And so where stigma comes from is this othering of people who have these disorders. And this othering occurs in a vacuum, right? If your idea of someone with schizophrenia is someone who is self-dialoguing under a bridge, that's going to give you one idea of that diagnosis versus if you have someone who is a peer or someone who is in recovery, who's sitting in front of you, who you relate to, who you're having a normal conversation with, that is going to drastically shift how people think about this population. One of the things that we run into, right, is there's this idea that they can't get better, that the illness isn't real, that treatment doesn't work, that they won't engage in treatment. And the biggest rebuttal to that is to put a living, breathing human being that they can relate to across from them, right, who can show that all of those things are untrue. And so, sure, as a psychiatrist, I can tell you I've seen things work. I can tell you that I've seen medications be effective. It's really different for somebody to hear the lived experience of someone who has made that journey from being highly symptomatic and significantly impaired to someone who is living a life in active recovery. And so this is an area where I think we really have to use more of our collaborations. We have to have those collaborations if we don't have them already. But the most effective messenger around the possibility that mental illness is treatable, around the imperative that this population deserves our care and our investment, are those with lived experience who have benefited from that kind of care and that kind of investment. Question number 6. I am a child psychiatrist who treats kids incarcerated in the juvenile justice system, both those who have and have not been adjudicated. What can I do to improve care, help address the impact of trauma, etc.? Thank you. this was greatly needed. So I also am a child psychiatrist who has worked in the juvenile justice system. And I'll say that trauma is the rule there. It's not the exception. If trauma is not in their chart, it just means that child has not felt comfortable enough to disclose that the trauma occurred, not that it hasn't taken place. And so just understanding that it is going to be part of the story, whether you know it or not on the front end. It's an area where I think we can liken it to universal precautions, right? We wear gloves when we're doing medical procedures because we assume that people could have things. The same goes for trauma-informed care. One of the issues with trauma and how we screen for it is that, like most things in this country, our tools are not developed with marginalized populations in mind. So if we look at the youth who are overrepresented in the juvenile justice system, they're often marginalized, multiply so, but by things like race, class, and disability status. So our questionnaires may not ask questions in a way that are culturally relevant for them. They may not ask questions in a way that they can wrap their heads around cognitively. And frankly, often they do not ask the right questions. So if you're using something like the original 10-question ACE questionnaire that was normed on a largely white, largely middle class, largely college-educated group of people in Northern California, there are things that is not going to prompt you to ask. It's not going to ask about things like neighborhood violence or race-based traumas that are going to be highly relevant to your population. And so one of the things that you can think about is what instruments you're using to screen for trauma, what populations those instruments were normed on, and also looking at the population in your local community. It's very easy to look up crime maps, for example, of certain zip codes. So whether the child tells you that they were exposed to community violence or not, if you see a sky-high murder rate in the zip code where they grew up, you know they were exposed to it, right? You also know that maybe these are things that you need to ask about specifically, given what you understand about the broader community. Question 7. Just as it is imperative for clinicians to develop rapport with youth that present in the justice system, buy-in and participation from their family is essential. How would you best encourage family involvement? So there was something that we touched on in the panel around reframing, but also repair. And I think that is something that is really critical. As mental health professionals, we often go into situations with our best intentions. We haven't harmed the person. We want to help them get better. But the reality is a lot of people who should have helped them, a lot of people who should have helped them get better, a lot of people who were part of systems that said they were working in their interest, quite frankly, have not. That systems, quite frankly, have not. And so there's something that we have to do in not taking it personally when we are looked upon with some degree of distrust, right? When there is some degree of not wanting to engage with us, we can't take that personally. We have to understand the larger context that's occurring in. For families, especially when we're thinking about youth in the juvenile justice system, we know that there's a lot of cross-system involvement. So youth in the justice system are much more likely to have child welfare system involvement, or their family is much more likely to have that compared to youth in the general population. And so a lot of times these families have fears related to people thinking they're not suitable, to their other children being taken away, to disruption, or to their children being taken away again, right? And so understanding what their fears are, understanding what their concerns are, is going to be really important. And to the degree that you're able, providing reassurance around those things, telling them what you're there for, what you're not there for, telling them who you report to, who you don't report to, who you share information with, who you don't share information with, are all going to be really important. Another thing I'll say for families that have mixed documentation status, right, that may be worried about engagement with immigration authorities, being candid and upfront about who is involved, who you report to, who you talk to is also going to be really critical. And when it comes to families, long term, just as you need to show up for that child consistently, it's important that you show up for that family consistently. And it may take time. It may take a period of time where you are showing up consistently before they can trust that you're going to do that on a regular basis. Something I see a lot in medicine and in mental health, right, is that we have an idea of who the professional is, and we equate kind of professionalism and education with expertise. And it's important to understand that we have expertise as it pertains to mental health, But that family has expertise as it pertains to their stressors, their strengths, their values, what motivates them, what doesn't. And so understand that they have expertise to bring to this too. Treat them as partners in understanding what's going to be helpful and potentially harmful to them, and making space for that. I educate psychiatry residents and medical students and child psychiatry fellows. And part of what we talk about is the application of what we consider evidence-based or best practices. So we can write a prescription for an FDA-approved medication, but if the patient doesn't take it, that FDA approval really doesn't mean a whole lot, right? So the best intervention is one that is clinically indicated and that the family is able and willing to carry out. All of those things have to go together. And you don't know what a certain prescription or what a certain treatment course means to a family unless you give them space for that and recognize them as experts in their own way about their illness, about their strengths, about their traumas, and about their resilience. Question 8. I am a psychiatrist at my county's local jail. How do I get involved in the JPLI or other resources? So JPLI stands for Judges Psychiatrist Leadership Initiative. It's a collaboration between the Council for State Governments and the APA Foundation and a judicial system that I'm forgetting the acronym for at the moment. But certainly if you Google Judges Psychiatrist Leadership Initiative and APA Foundation, you will find it. We are, and I say we because I'm one of the national co-chairs of JPLI, we are certainly looking for psychiatrists who are willing to do co-trainings with judges, for judges, about these issues of mental health and involvement in the criminal justice system. At JPLI, we have developed a curriculum, and it can be taught, I think the longest version is 6 or 8 hours, but there's also a shorter 4-hour version. So you don't have to come up with slides yourself. This is a curriculum that we have developed over time, that we have vetted, that we have refined, and it's clear, what the psychiatrist's slides are, what the judge's slides are. We have embedded videos, and so we make it as user-friendly for people who want to get involved as possible. You don't have to come up with any new slides or anything like that. We just need somebody with the expertise of being a psychiatrist and working with people with mental health conditions to help answer questions for the judges and to provide local context to the content. And so it's a great way to get involved. Another thing that I will flag is the potential to be part of crisis intervention training or CIT training. So this is something that is usually administered by a mental health professional and is given to police officers and first responders across the country. So that may be something to look into at a local level as well. Question number 9. I work for a forensic ACT team. Are you aware of peer support specialists accompanying NPs? I'm thinking that's our nurse practitioners going into jails to assist with building that rapport and trust to engage individuals with SMI in treatment. It's funny you would ask this question because I'm chair of psychiatry at Morehouse School of Medicine, and we recently have engaged in something very similar to this there. So Fulton County, which is the county seat for the city of Atlanta, their district attorney's office has a grant from the Department of Justice that is looking at folks who were unfairly or unjustly sentenced. So it's not that they didn't do it, but it's just that their sentence was way too long given the nature of the offense. And so they're going back, looking at these cases, letting these people out, quote unquote, early, but really the time they should have been let out. But they understood that for a lot of these folks, mental illness was going to be a significant concern, and that successful reentry was going to be dependent on them having some mental health supports that were part of that plan. And so they actually made our department, the Department of Psychiatry at Morehouse School of Medicine, a sub-awardee of their Department of Justice grant so that we can help them with that work of helping them transition to the community, providing mental health services, case management, psychotherapy, trauma-informed interventions, and things of that nature. And so it was an interesting process sitting with the DA's office and this team from the prosecution as they were thinking about how they were going to set this program up and how they were going to involve us. And one of the things that I encouraged them to do from the very beginning, even though it would potentially decrease the amount of money that came to our department, was to really think about what it would mean to center peers in the work, center peers in the proposal, and to involve them throughout the process so that for these individuals returning to society from prison, not only do they have our social worker who is part of our psychiatry department that is engaging with them early on, but they also have peers that they see are part of the team that have successfully been able to reenter society themselves. And they have that example from the very beginning before they even get out. And so I'm not sure of how common that is, but I do think there is a growing awareness for the need to involve peers early on. And when you think about mental health workforce expansion, when you think about being cost effective, there are also very compelling arguments to be made for peer involvement there as well. Question number 10, how can street medicine teams, homeless outreach teams leverage services to combat some of the serious mental illness treatment challenges? So when it comes to mental health treatment, removing barriers to care is critical, especially for those who may have unaddressed and highly impairing symptoms. So when you have outreach teams and street medicine teams, you are removing transportation barriers, you're removing geographic limitations of clinic barriers, you're removing some of the barriers that their symptoms may present in terms of initiating that care. And so these are critical, right? These are critical for reaching the folks who need help the most oftentimes, and they're also critical for intercepting before someone ends up involved with the criminal justice system, right? In order to get involved with the criminal justice system, you don't have to take yourself to jail and sign in and sign up to go to jail. The cops come to you, right? And so if cops go to people and engage people on the street, if we want to get to them first, if we want to divert them, we're going to have to go to people too. Question number 11, how do we go about getting court-ordered long-acting injectable treatment? So this is something that is going to vary depending on where you are. I would say the best source of information for this may be like your local chapter of organizations like the American Psychiatric Association. It may be also people who are involved with specialty mental health courts who would have an idea of what that looks like where you are. Question 12, do you have any thoughts on competency, capacity, in treating patients with severe symptoms who are not under court-ordered treatment and would not qualify for COT? But I'm thinking that COT is court-ordered treatment. So, and I'm assuming here that competency is like competency to stand trial. So one of the things that we have done from a legal standpoint, an attempt to protect people, is that anybody who is potentially not competent has a legal right to be evaluated for competency to stand trial, which is interesting because you don't have a right to a mental health evaluation just to see if you're okay or to get treatment in this country, but you do have a right if there's a question of legal competency because there's a concern that your legal rights could be violated if you are forced to go through a legal process without having competency to stand trial. And by competency to stand trial, broadly speaking, you mean that the person is with it enough, can follow things enough to advocate for themselves and assist their lawyer in their defense or assist their lawyer in kind of the plea bargaining process is practically what ends up happening most of the time. And so what we have, because there's a right to these kinds of evaluations and there's a right to competency restoration or treatment to get people competent so that their cases can move forward, is that an inordinate amount of money of state mental health budgets is spent on competency and competency restoration. And in a lot of cases, the alleged crimes are misdemeanors and people are waiting in jail or in psychiatric hospitals trying to get competent. And so objective of competency restoration is quite narrow, right? It's that the person just gets well enough to move forward with their case, but you can end up spending a lot of money on it, and the person can end up spending a lot of time incarcerated because of it. And so what some jurisdictions have started to do, and Judge Leifman in Miami is a huge proponent of this, is that if there's a competency issue for a minor crime, that you don't even take that route. Because most of the time what happens is the person gets out with time served, and after you've spent $1 million on a psychiatric hospitalization to get them better, they go back to the community with no services. And so a lot of states are starting to rethink, is it worth going through the competency restoration process for people with misdemeanors and even people with certain felonies? And how can we use that money so that rather than it being applied to this very narrow competency restoration process, that it's applied in a much more holistic, recovery-oriented way to increase that person's likelihood of successful societal reentry and recovery. So I think that is all the time I have. Thank you so much for your questions and your thoughtfulness, and I hope my answers prove useful to you, and I'm happy to continue this dialogue in our professional communities.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.